Here is the question.
Yeah.
Yes, still 18 seconds left.
Okay.
Right, so if you have read and understood, kindly begin your history taking.
Hello. Hello. Hello.
Hello.
Hi, my name is Ruchi. I'm one of the medical doctors. Can I confirm your name and date of birth, please?
Okay, my name is Robert. 54 years old.
Oh, hi, Mr. Robert. What brought you to the hospital today?
Okay, so for the past let's say 6 weeks, I've been having difficulty breathing. That's why I'm here today, and then I do have discomfort too under my chest.
Okay. You said it's been 6 weeks now. What about
Yes.
before 6 weeks? Were you completely fine before 6 weeks?
No. Before 6 weeks, I've been having the same complaint, but it got worse over the 6 weeks now.
Okay. And when we say it got worse, when you feel it is worse, is it when you're walking, when you're sitting, when you're lying down?
Even at rest, it's really bad.
Okay. And is it like something which is all the time or it comes and goes?
Yeah, it's been persistent. It's all the time.
It's all the time. And it does get worse when you start walking.
Yes, it gets really bad.
It gets bad. How much you can walk before you have to sit down?
Mm, just a meter, and then I'm tired.
And you think this distance of meter, is it increased, decreased, or still the same in the last 6 weeks' time?
It has decreased.
It has decreased. Okay. Do you notice any pain in your chest?
Yes, I've been having discomfort actually around my chest.
Is it just a discomfort or is it actually painful?
It's just
Just
discomfort.
discomfort. Can you explain it a bit more when we say discomfort? Is it like, do you feel tightness in your chest or
Yes. Oh yes.
chest
I feel
tightness?
like it.
And is it specific with your difficulty of breathing? Do you think it's related to it?
Yes, it's specific. Yes, I think it's related.
Okay. And is this discomfort all the time or is it just when you feel short of breath?
Even at rest, always, I'm having like discomfort always, even at
Okay.
rest.
But you don't have any pain in the chest?
No,
No,
not
not really.
really. Sometimes I do have chest pain, but not really this story.
Have you noticed any swelling in your legs in the last 6 weeks' time or before that?
Um, no, no
Okay.
swelling.
And have you had any similar symptoms in the past?
Yes. So I was admitted about 4 months ago because of pulmonary embolism. They told me. Yes, and
And
then I was on medication.
okay, and what medication you are taking for pulmonary embolism?
Right now I am on warfarin.
On warfarin, and you are taking it regularly as advised.
Yes, I am.
And we didn't actually miss any medication in the last 6 weeks' time or before that.
No,
No.
no, I've not. I've not missed.
Before the 6 weeks, have you had any surgeries done?
No, no. Apart from the, no, I've not had any surgery.
No surgeries. Okay. And anything which you feel like in the 6 weeks time, your mobility, or you have been noticing a decrease in your mobility or spending more time just sitting down or lying on the bed?
Yeah. Yes.
Okay. Have you noticed any change in your weight?
Hello.
Have you noticed any change in your weight?
Yes, I've lost a lot of weight,
How much weight we are
but
talking about?
I've lost about close to about 10 pounds.
In how much time?
Over 8 weeks.
And it's
I'd say.
unintentional. It's unintentional.
Yes, it's unintentional.
It's unintentional. Okay. Any other medical problems?
Yes, I have COPD.
Any other medical problems like diabetes, hypertension?
She said COPD. Next question.
No, only COPD.
Okay. And you are taking inhalers for that?
Yes, I'm on medication for it.
Okay. Any other heart problems?
No heart problems.
Okay. Anyone in the family with the history of cancer or with the pulmonary embolism?
No, please.
No. Okay.
No.
And any other medication you are taking apart from the inhalers?
No, only the medication for the COPD and then the warfarin.
And the warfarin. Okay. And do you have any allergies?
No allergies.
No allergies. And who is at home with you? Hello?
I live with my wife.
Okay.
I live with my wife.
Okay. And how is your mobility? Do you walk with a stick, without a stick?
Right now, like I said, more of discomfort, so I don't walk much. Even if I have to, I need her support.
What do you used to?
I have a walking frame.
Okay. And do you smoke?
Yes, I used to smoke a lot, but I stopped.
How much you used to smoke?
Yes.
Hello?
I used to smoke about 26 per day, like a whole time a day.
And for how long you have been smoking?
I've been smoking for the past 30 years.
30 years. And for her, and when did you stop smoking?
About 5 years ago, when I was diagnosed
with COPD. Okay. How much is do you drink alcohol much?
Occasionally.
Occasionally. Okay. Right. Is there anything else you want to add on which I didn't ask and you feel like I need to know?
Nothing much, doctor. I think you have asked me the questions.
Okay. So just to summarize what we have discussed so far, you have this ongoing shortness of breath.
It's history taking, so you'll summarize the case to the examiner. So can you summarize, yes, your history taking now, please?
Okay, fine. Thank you so much, Mr. Roberts. I'll talk to you later.
Okay, you're welcome.
Right, so we have a 54 years old Mr. Roberts presented to ED with the shortness of breath going on from last 6, the chronic shortness of breathness which got worse in the last 6 weeks.
Yes.
And it's more, sorry?
Yes.
Yeah, and it is more worse even when he's sitting down. It has decreased his mobility and has restricted him indoors. He reports no swelling in his legs, but he did have a history of pulmonary embolism diagnosed 4 months ago and for which he is currently on warfarin and has complied with his medications. He is known to have COPD and is using inhalers for that. He does not have any significant family history of cancers, but he does have a red flag symptom for cancer in his history, and that's an unintentional weight loss of 10 kgs in 4 months.
So what are your differential diagnosis?
My top differential in his case would be because of his COPD, it can be an acute exacerbation of his COPD,
Okay.
and it can be another episode of pulmonary embolism.
Very good. And
I would still like to exclude heart conditions in his case, mostly the stable and unstable angina.
good.
It's unlikely it would be a MI, but I would like to do blood investigations like troponins and ECG to exclude that.
Okay. So what else should be included in the management?
From the management, I would like to examine this patient, the cardiovascular exam and the respiratory exam. I would like to repeat some blood investigations like full blood count, HB, UNEs, and INR. I would also like to do ECG and
Very
send
good.
some
Chest
cardiac
X-ray.
markers.
Yes.
And I would still do a echocardiogram for this patient as well to rule out the heart conditions. And I will get a chest X-ray.
Okay. CTP and
If
VQ
chest
scan.
X-ray
Okay. What
doesn't
should be the treatment for this patient? Last question, Belvin. Yes.
So this patient is already on warfarin. If a CTPA did show that he has got a pulmonary embolism, then he will probably be a candidate for IVC filter.
Okay.
But I would like to discuss it with my medical colleagues to get into more further management.
How what is one single test that you should do or you will be doing it to confirm if patient is having any event of thrombolysis or
D-dimers?
no, APTT?
Sorry, what test?
APTT, which should
Okay.
be like between 50 to 60 seconds, and if it's that, then you'll give heparin until APTT is 50 to 60 seconds, and if it's then it's non-massive thrombolysis, and if it's more than that, then this is massive. Then you'll ask for IV filter, like
Okay.
that you have told, embolectomy, and then IV filter.
Okay.
Correct me if I'm wrong. This is what I know. Thanks. Right. Who will give feedback to Dr. Vajia? This was her first time she did history taking, and obviously, when you think that you can do it, it doesn't happen, right? She took more time, at least 2 to 3 minutes, because yeah, we understand it's virtual, so we are not having signals or it's not clear all the time. But if just suppose exam becomes remote, you all will face the same problem. The only thing additional will be there'll be camera on, and you'll be looking into the face of the other person, and then you'll be asking all these questions. But then this does not guarantee that voice cannot be interrupted or voice one cannot hear each other simultaneously or whatever. So digital problems will still be there. So what are the things which Dr. Vajia have missed in this history? Yes, doctor. Someone had raised hand. Yes, please. Doctor.
Ma'am, actually, I
Yeah.
needed to ask that, that as you have mentioned that we should go for IVC filter, like in such patient, can't we go for streptokinase LTPs like stepwise? That you already
Yes,
patient on
you'll go
warfarin and has
stepwise. This
been.
is what I was trying to say, because Dr. Vajia mentioned straightforward that if it will be, then she'll go for IV filter. But there are certain things you have to do
Okay.
before you jump to IV filter.
Okay. Okay, ma'am. Thank you.
Yes. So anyone, all right, you asked for, you wanted to rule out that if there is no heart problem or not, but still you forgot to rule out regarding to shortness of breath, orthopnea or paroxysmal nocturnal of dyspnea. Maybe
Yeah.
you didn't ask associated cough, if there was any.
Yes, I forgot that as well.
Yeah, and what else? Timing you did ask. At what time you have shortness of breath.
Yeah.
Exacerbating and relieving factors, maybe as well you asked. When you asked about the chest pain, she was saying it's discomfort. So you did try to rule out that it was not MI.
Yeah.
Yeah, good. So that was it,
Or
I
is
think.
there any?
Yes?
Ma'am, is there any significance of asking about leg pain and all that? Because you asked the patient about ambulation, they said he's little bit little less ambulatory. So
Yeah,
could
she
be a
did ask
DVT
that.
also a cause.
Yeah,
Okay, okay.
yeah, she did ask that
I might
to
have
rule
missed.
out. Yes,
Okay,
yes, Dr.
okay,
Mohammed, you
okay,
were
ma'am.
saying something. Dr. Mohammed Ilyan, you wanted to add something?
Yeah, I also I am asked the pain worse in movement to exclude
Yes,
musculoskeletal.
yes, she did ask that. She did ask that. Good. Yes, knowledge part was very good, but one or two
Okay.
things because she hadn't practiced it. She didn't know this question will come. It was totally random and surprise station for her.
Sorry,
Yes,
I am here in history. The patient is lose weight during this period.
yes,
Yeah, we should keep them in our mind if there is any sinister cause like lung cancer and complicated by
yes,
dyspnea.
yes. She did have this in her DD, and she did ask relevant questions
Yeah,
with us.
and in management, I don't hear she asked about ABC because the patient
She did
presented
not
to
say
ER
that.
and
Yes, very good.
he
Yes,
presented to ER and he complained of shortness of breath. We should
yes.
start treated with ABC.
Yes, this is history taking, and then when you ask how would you manage the patient, so once you were telling about the investigations, then when I asked you for the treatment, then you can say, I'll ask the patient according to ABC protocol, and
No,
then
I
you
thought you
can,
said I missed the arterial blood gas. I should have asked about the arterial blood gas.
yeah, ABGs as well, yeah, that as well, because patient was in ER and patient was with the complaint of dyspnea, so ABG as well, yes, very good. Even I missed it while giving you the feedback. Yes, so yes, that protocol is one of the way of telling you telling the treatment. Like first you did the exam history, and then you'll do the complete examination, and then you'll begin with the okay investigations you told me all, and then treatment when I asked you, then with ABC protocol, and then okay you'll consider what you'll consider depending upon what you get the answer.
Yeah.
So yeah, good. Anyone else want to add anything? It was good considering that you did it for the first time, but I don't know if you're practicing it with any of your friends or
No, I'm not. I don't really practice history and stuff. I just do it at work. So
yeah, yeah, but the here time is our enemy, so you have to time yourself and then you have to practice it with that. Good. Started the timer, and here is your question. Sorry. Right. If you have read and understood, kindly tell me what are you looking at.
This digital section of the brain,
Yes.
MRI digital section.
Okay. Can you please identify number 4 for me here?
Fourth is the cerebral aqueduct.
Very good. Can you identify number 6 for me? Yes, here above.
This is the corpus callosum, the body of the corpus callosum.
Yes. And number 8, please. 8 is here at the bottom.
This is the cerebellum tonsil.
Yes. And 10, please. Yes, here, 10.
Then this is the cerebral peduncle of the midbrain.
Yes, good. 13. 13 is here. 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 13 is here Where is 13? Yes, here, please.
See, this is the cisterna magna.
Yes. And 15, please.
50, this is the fourth ventricle.
Fourth ventricle, good. 16. 16 is here.
This is the medulla oblongata.
Okay, and 18. Here is 18.
This is the splenium of the corpus callosum.
And 19, please. 19. Yes,
This
here,
is the
sorry.
thalamus. The
Thalamus.
thalamus.
Yes. Okay. Can you please tell me different how many lobes there are in cerebral hemisphere, and what are their boundaries?
Okay, there is the frontal lobe, and there is the parietal lobe, and the occipital, and the temporal lobe. The frontal
Okay.
lobe
Yes.
from the anterior pole of the frontal.
Yes.
Posterior, it is bounded by the central sulcus.
Yes. And temporal
The
lobe?
temporal lobe, there is a superior lobe and inferior lobe.
Yes.
Superior lobe is bounded by the lateral fissures,
Yes.
and there is the parietal lobe. Anteriorly, there is the central sulcus. Posteriorly, there is the calcarean sulcus. Inferiorly, there is the occipital lobe bounded.
Of temporal lobe. Inferiorly, there is temporal pole.
Yes, temporal
Yes.
pole. I mean
Yes.
occipital lobe. Anteriorly, there is central. Superiorly, there is calcarean sulcus.
Yes. Parieto-occipital sulcus, and posteriorly there is occipital pole. Okay. What about parietal lobe? Anteriorly there is central sulcus,
The
and
central sulcus, posteriorly parieto-occipital.
yes, and inferiorly lateral fissure.
Lateral fissure.
Okay. Can you please tell me within which lobe are areas auditory cortex located?
The temporal lobe.
Okay. Right. Temporal gyrus. Okay. And then visual cortex,
Occipital.
and then olfactory cortex.
In the frontal lobe.
Okay. Can you please tell me what is the function of corpus callosum?
Corpus callosum, this is the provide interconnection between the two cerebral hemispheres.
Okay.
It's connect the right and left cerebral hemisphere and vertical from right to left all right.
Can you please tell me what are the different parts of corpus callosum?
There is the genu, the corpus
Yes.
callosum
Yes.
anteriorly, and
Yes.
there is the body and the splenium.
And there is rostrum, genu, body of
Colostrum.
corpus callosum, and splenium. Yes.
Yes.
Okay. Can you please tell me what are which system in the brain does the structure labeled which is pituitary gland located?
Sorry?
In which system in the brain does the structure pituitary gland belongs to?
Uh,
What is the function of pituitary gland?
there is a secretion of the corticotrophic releasing hormone, adrenocorticotrophic releasing.
Yes.
It
All right.
is,
Have you heard of limbic system?
yes,
Yes. What does it do?
it will provide coordination for the learning,
Yes. And pituitary
memory,
gland is part of,
learning.
yes, it's part of this system, right? Okay. Can you
The pineal gland or the pituitary? I think it's the pineal gland.
pituitary gland? Sorry, mammillary
Okay,
gland, mammillary body. I'm sorry. Yes,
mammillary. Okay,
my bad. Yes.
okay.
Okay, I'm sorry. Yes, my wrong. Okay, can you please tell me which are the vessels which contribute to form basilar artery?
The two vertebral arteries, the right and the left vertebral artery.
These are branches of which vessel?
The subclavian artery.
Okay, very good. Excellent. Can you please tell me the boundaries? You've already told me of the cerebral lobes. Can you please tell me the boundaries of cerebral lobes? What do they have anteriorly and what do they have posteriorly?
Cerebral lobe.
Yes. Boundaries of different cerebral lobes.
There is a frontal lobe
Yes.
bounded posterior by the central sulcus,
Okay.
and there is the parietal lobe anterior is the central sulcus, and posteriorly the parieto-occipital sulcus, and inferior there is the lateral fissures. Occipital lobe, there is the parieto-occipital sulcus, and there is the calcarean sulcus inferiorly. The temporal lobe, there is superior pole and inferior pole.
Can you please tell me what you understand by subarachnoid spaces or cisterns?
This is a space which is separation between the arachnoid and the PMR.
Okay. Can you name them? Name few.
There is the interpeduncular cistern and supracella cistern and cisterna magna.
Okay. Can you tell me how CSF is produced?
It's produced in the lateral ventricle by the coarse choroid plexus.
Yes.
Then it's passed through cerebral aqueduct into third ventricle to the foramen of Monro.
Yes.
From the third ventricle to the fourth ventricle via cerebral aqueduct.
Yes.
Then to pass to subarachnoid space via the lateral foramen of the Leschisca, and there is the median foramen of Magindi.
Yes.
From the subarachnoid space to the arachnoid villi.
So if there is obstruction in the flow of CSF, where would you find it to be most commonly present?
Most commonly, the cerebral aqueduct.
Yeah. Can you tell me what you understand by Arnold-Cherry malformations?
It is downward displacement of the cerebellum tonsil through the foramen magnum, causing non-obstructing, non-communicating hydrocephalus.
Yes, good. Bell is gone, but I'm just going through if I've missed anything. Okay, all right. Right, mostly I think I've covered. Thank you so much.
Thank you.
Okay, thanks. I'm starting the timer, and here is your question. Once you've read this first slide, please tell me. I'll move on to the second one. Yes, moving on to the next slide.
Yeah.
Wait, man.
Right. If you have read and understood, kindly begin your examination. Begin your step.
Okay, ma'am.
Yes. Call your cardiothoracic consultant.
Okay. May I start?
Yes, please begin.
Okay.
We've
Hello, my
already,
name is
yes.
Dr.
Yes.
Surgical Training Level 1. I'm working for uh, Mr. Rahman at the Queen's Hospital. I was calling to speak to our cardiothoracic consultant on call, Mr. James, to ask him to accept a referral for a patient who was presented to us with a widened mediastinum. May I know who am I talking to?
I'm Mr. James.
Right. Uh, Hello, sir. So I have a patient, he's a 23 years old gentleman who was presented to us after a motorcycle road traffic accident with a GCS of 14 by 15. When he's currently he has a heart rate of 120 beats per minute with a blood pressures of 100 by 80, and he has a swollen left thigh. And our chest X-rays show bilateral pleural effusion and a widened mediastinum. So we had to put in a chest drain for which through which we have drained approximately uh, 120 ml of blood, and we are unable to perform a CT scan because the CT scan machine is out of service for the next 3 days. So I was wondering if we can ship this patient to your hospital because this patient's current hemoglobin is 8 and his current ABGs show that he has a pH of 7.3 with a PaO2 of 10 kilopascals and PCO2 of 6 and bicarbonate of 19.
With the HB of 8, do you think this patient will survive the transport?
Good.
Uh, So I think we have already resuscitated him, and during this resuscitation, I think this we can manage to transport him.
What you have done so far in resuscitation?
So we have started him on 4 liters of crystalloids that have been given, and we have arranged for 6 units of blood which are on standby and can be given if they're needed.
When do you plan to give him the blood then, if his HB is already 8? What's your plan?
So since we can see a widened mediastinum on the chest X-ray, I was concerned that this patient has probably suffered some injury uh, to his ascending aorta. So we were planning to shift him to your hospital where we can plan for his further treatment and plan of care.
Do you think this patient is stable enough for transport?
Okay, sir, I think if we can stabilize his fracture his fractured femur by using a Thomas splint and
He's got a fracture
stabilize.
as well. I thought you want him to be transferred for widened mediastinum. He has got fracture as well. Where's the fracture?
Yes, so for the fracture, if we stabilize it using a
Where is
Thomas
the
splint,
fracture?
and if
Listen carefully. Where is the
he has a
fracture?
swollen left thigh, and the X-ray shows that he has a fracture of the left femur. So if
The open
we
fracture.
stabilize his,
Is it open
I'm
fracture?
sorry,
Is it the open fracture? Is he neurovascularly intact?
no, it's not an open fracture, and the neurovasculars are intact.
Okay. You worried about the fracture?
Yes, but so far I'm more concerned with the widened mediastinum. So this is why I'm going to stabilize this fracture with a splint and plan to shift him as soon as possible.
Do you think this patient is stable enough for transport?
So I think if we can, right now we can shift the patient. Yes.
So he's stable enough with the
But
ABG of 8 and what are the parameters you told me? You think he's stable enough for transport? How are you going to arrange the transport?
okay, so I think I'm going to accompany the patient myself, and I'm going to take one of my anesthesia team members or one of the physicians from the ITU to accompany the patient.
Please tell why the blood pressure should not raise.
Okay.
What is the fear?
Okay, you have given him 4 liters of fluid or something. Does it make
Yes.
any difference to his blood pressure?
Okay. Well, we have a high chance that this, like if the blood pressure goes higher than this, there's a high chance that there might be increased hemorrhage. So I would like to keep those blood pressures on the relatively lower side.
Right. And what else I can ask? How you plan to transport him? How you gonna arrange the transfer?
Okay, so I am going to transport the patient in an ambulance with one of our anesthesia colleagues or a physician from the ITU along with myself. So I will come with the patient.
In how much time? Do you think this patient needs to be blue lighted?
No, I don't think so. We need to put it on the blue light, but yes, we do need to shift him as soon as possible.
Okay, what about the cervical spine?
Have
Okay.
you examined? Have you immobilized his C spine?
Okay. So we are going to immobilize the C spine using a hard collar.
And sandbagging. Okay.
Okay.
What
And
about the metabolic acidosis?
okay. Yes. But have you done the ABG on him?
We did an ABG, and
What
the
did it show?
ABGs show that he has pH of 7.32 with a PaO2 of 10 kilopascals and PaCO2 of 6 kilopascals at bicarbonate of 19.
What
He
does that mean?
probably has metabolic acidosis. He probably has metabolic acidosis, and this could be because that the patient has lost a lot of blood because of his closed femur fracture that might be pushing him towards a compartment syndrome.
Good.
Compartment
Also, the
syndrome
patient
where?
is non-diabetic. Also, the patient is a non-diabetic, so he might be going towards diabetic ketoacidosis.
Very good. What about the abdomen?
Yeah. Any other concerns apart from the chest and the thigh? Are there any other injuries
Uh,
you're concerned about?
on one of his abdominal X-rays show that the psoas shadow is absent, which is probably denoting that there is an intra-abdominal collection as well. So he might need a laparotomy for that.
And what you have done for the chest so far?
Okay, we have inserted a chest drain that has drained approximately 120 ml of fresh blood because he has bilateral pleural effusion.
Does it say in the question? Okay.
Just okay. Yeah.
Yeah. Okay. And what is his GCS now?
Okay, currently he has a GCS of 14 by 15.
How do you calculate GCS? Sorry, it's a mean question.
Yeah. Okay, if you can summarize everything to your consultant now.
Right. So we have a 24-year-old gentleman who's a non-diabetic who is presented to us with a history of a road traffic accident with a GCS of 14 by 15, with tachycardia of 120 beats per minute and blood pressures of 100 by 80, and a left swollen thigh. And upon workup, he has a widened mediastinum with bilateral pleural effusions, for which we have inserted right side chest drain. And uh, since our CT scan is out of order, we have to shift him to a cardiothoracic unit where he can be managed accordingly.
Good. Yeah, are you happy? Should he send his patient to you?
Well, yeah, that's fine. Send him across. We'll have a look. We'll sort him out.
Good.
All right. Thank you so much.
Thank you. So still I turned the clock on, so 18 seconds are left. Good. Right. Who will give feedback? Thank you. Within the hours and it's too light.
Well, it needs to be blue light here, by the way.
Yes.
And yeah,
Start discussion. Yes.
yeah, that's why I specifically asked you how you're going to transfer it, and that's the only thing I wanted to hear, that you're going to blue light him.
Yeah, you would. You would.
Mhm.
So that was some correction that we could do on the spot.
And the other thing was, I keep asking you if the patient is stable or not, if patient stable is or not. All I wanted to hear was that he's stable now for
Yeah,
transfer, but he
yeah.
might not be stable after this much time. So we have stabilized him. That's what I wanted to hear.
Yeah, this is something you have to stress
Yeah.
on when you're asked that you
That's
should.
what I said, that the patient
In the
is
beginning,
stable at
you
the
said
moment.
it once. Then she asked you again. You should have stressed again. Yes, we have stabilized the patient with 6 liters of fluid, and blood has been cross-matched and is ready, and patient is stable right now, but may not be if we waited. Yes, like she's saying. So good.
Yeah, you said that point was really good when you said you're going to transfer him yourself and IT, though that's never going to happen in practical life, but that was a good point.
Yeah.
Yeah, that was a good point. And also, when I asked you what you have done for optimization, you mentioned that these things you have done, but you can actually mention about that monitors are arranged. We are continuously monitoring him with the oxygen and all those things because you have done all those things. And the other thing was, I specifically asked you about the fracture, whether it's open or not, because I can see it's not. It's documented in the question that it's not. But there's no documentation about his neurovascular status.
It was assumed to be that.
No, it's documentation about neurovascular status in the question, and you said he's neurovascular intact. To my knowledge, to my understanding, if there's nothing documented in the question, you just say that you don't know rather than saying yes or no.
Rather than making up the answer.
Yeah.
All right.
You can say, I'm not sure, I'll get back to you for that. In exam, if you don't know anything or you have not seen the answer, do not lie, please. Exam is closed and you have to feed this in your subconsciousness, each and every one of you. If you don't know the answer or you have not seen the question, just say, I'm not sure about it, I'll get back to you for that. So don't make up the answer and don't say it, because then they will say, okay, person does not even read the data clearly, they just make it up.
Again, same goes for C-spine as well, because you asked me to ask him. Otherwise, there is no documentation about what you
there's no.
for his C-spine.
There's none. Yes. Yes. Good.
Yeah. Other than that, everything was fine.
Everything is good. Yes. And this is like Dr. Osaf's first patient for communication skills, I think. If I'm not wrong, yes. Very good. Considering it to be the first one. Those who have done many times practice, even they need to practice again. So it's very good considering, yeah.
Right. Thanks, man.
All right. Here is your question. Right. If you have read and understood, kindly begin your history.
Okay. Okay, I'll enter the room and I'll wash my hand, introduce myself. Hello, I'm Dr. Nadeem.
History taking.
Yes, history taking. Still. Hello, I'm Dr. Nadeem, one of the surgical candidates. May you please confirm your name and age?
Hi, I'm John. I'm 56 years old.
John, nice to meet you. You're 56-year-old. Okay.
Yep.
That's great. So how may I help you, please? Can you please tell me?
Doc, I'm having a couple of complaints actually. I've noticed this dark discoloration of my urine. It's more bloody, and it's been ongoing since the past 5 weeks. And also, I'm noticing there's a pain on my left side of my tummy, my lower aspect, and I'm just tired. I'm just exhausted all the time.
Oh, John, I can really feel your pain. Okay, that's right. So may I please ask you a few more questions, if you don't mind?
Yeah, please.
Okay, that's great. So just please tell me first about this, blood which you noted in the urine. So you said that
Yeah.
it's for last 5 weeks. So did it? Is it the first time it started, or did you have such episodes even before?
No, this is the first time I've noticed it. No, I've never noticed it before that. It's been going on for a little over a month now. About 5
Right,
weeks,
John.
you might
And
say. Yeah.
can you please tell me if you have this blood with every urine you pass, or does it go and come?
Yeah,
in
it's
better?
more or less continuous. I mean, it's present every time I pass some
And is
urine
it?
now.
That's right. And is it mixed with the urine, or does it come at the starting of the urine or at the end? Do you remember?
I can't tell you seriously. It is completely bloody, so I can't actually tell you if it's in the beginning or later. It's all throughout.
Okay, no problem. Okay, no problem. Don't worry. Okay, just tell me if you have seen any clots in the urine, like
No,
thickening
not that I can
clots.
recall. No, not that I can
You can't-
recall.
No problem. No problem. Okay.
Mm.
Did you have any kind of burning in urine while passing urine?
No, not that I can recall. No.
Okay. And do you have any problem in passing urine in the routine?
No,
Like,
no.
okay, do you have to strain? You have to pass it forcefully, or does it flow smoothly?
No.
Mm.
I just noticed this
Okay,
pain in my lower tummy since the past 2 days. Otherwise, it's all fine.
Oh, I'm really sorry for that. So can you please elaborate that? How is the pain? Is it dull, or something like sharp knife?
Yeah, it's like a dull pain, and it's on my left side. It's going all the way towards the back and coming towards the front, if I may say so. It's going down my
Okay,
left
John.
side of my
And
tummy.
right, John. And can you please tell me the intensity of the pain from 1 to 10? Can you score it? How much it is disrupting your daily
Might be
life?
around a 6 to 7.
That must be distressful for you. I can understand. So, are you taking any medications for all these things, for this pain?
No, when it gets very worse, I actually have some paracetamol. Sometimes it gets better, but otherwise it's just there all the time.
And anything which increases this pain?
No, nothing that I can recall now.
Right. Do you have any vomiting? Have you noticed any vomiting?
No.
Or any fever?
No.
Like temperature?
No.
Okay.
No.
And did you have any history of stone, kidney stones or past stones in the urine?
No. I've not been, no.
Okay. Did you lose any weight in last 6 months or last couple of weeks?
Not that I can recall, no.
Okay, no problem. And what about your appetite? Like, are you eating normal?
I've been eating a little less. I'm not gonna lie, but I've been tired most of the time. That's also there.
Good. Okay, no problem. So, can you please tell me, do you feel dizzy most of the time?
Dizzy?
Do you
Not
have
really,
anxiety?
no. But I'm exhausted. I don't feel energized to get up from bed. I'm almost tired all the time. On bed all day.
Right. Understandable. So, can you please tell me, when you go upstairs or you go a little faster, do you feel any racing heart, or you are gasping for breathing? Do you feel difficulty in breathing and racing heart?
No.
Any chest pain? Okay.
No.
And do you have any constipation or problem with the bowel habits?
No, that's fine.
Or any tummy pain, other tummy pain?
Yeah, I've told you just now that I'm having some pain since the past 2 days. I'm having pain in my lower tummy.
Right. And what about your, like, if you don't mind, how is your sexual history? Like, are
That's
you okay
fine.
with
That's
that?
fine. Yeah, that's
Good.
fine. That's fine.
Okay. And now, what about your medical history? Do you have any diabetes, sugar, or hypertension?
I'm on medication for my hypertension, but my doctor says it's actually controlled.
Right. And did you have any kind of surgery before for this condition or any other condition?
What condition? Oh, no, I've not had any surgeries in the past. No.
Okay. Okay, you did not. And any of your family members who had cancer or some serious disease, if you can recall?
No, no.
Right. Can I please ask you a few personal questions if you don't mind?
Yeah, please go ahead.
Right, great. So what do you do for your living?
Nothing at the moment. Been furloughed because of COVID, so I'm just basically sitting at home.
Oh, that must be.
Sorry, I was a
hard
factory worker.
situation.
Sorry, I'm a factory worker.
Oh, okay. Do you smoke and drink?
Yeah, I've been a smoker. Yes, I do
For
smoke.
how many years? For how many years?
Should be over 30 odd years now.
What about drinks?
Occasionally, yes, I do have that as well. Yep.
Are you married?
Yes.
Okay, good. And what about any drug allergy? Are you allergic to any medications?
No, no.
Right. What specifically you expect us to do for you?
Oh, I'm really concerned about this. I mean, this pain has been going on for 2 days, and the bleeding, I'm actually concerned that it's something very serious.
Okay, John, I can understand. Don't worry, we are here to help you.
Yeah.
So thank you so much. We will see your labs and do all the workup. So please don't worry, right?
Can you please present your history now?
Thank you.
Okay, I have taken history from John, who had history of painless hematuria for the last 5 weeks, but he also complained of pain in the groin, which was also radiating to the back and down the leg. And there was no associated fever, but he has lost his appetite. But he did not mention anything about weight loss. Apart from this,
so what are your differential diagnosis?
Yes, differential diagnosis is TCC bladder cancer, prostate cancer, renal stones, or bladder stones, STDs, urinary tract infection.
Okay. How would you plan to manage this patient?
Okay, I'll do complete examination, and after that CBC, serum electrolyte, RFT, PTA, PTT, INR, and also this ultrasound KOB, pre-post white, with urine culture and routine examination, and also urine cytology for any cancerous cells. And depending upon the condition, I will also go for cystoscopy to take any biopsy if it comes out to be bladder tumor. And also,
and what should be the treatment for this patient? What should be the treatment for this patient?
So if it is a superficial bladder cancer, after staging properly and discussing in MDT, it will be transurethral resection of the bladder tumor. And if it is involving the muscle, then and it is also resectable and not metastatic, then we'll go for cystectomy with ileal conduit. And if it is metastatic, then we will go for palliative treatment with chemotherapy and radiotherapy.
Okay, thank you so much. This has ended. But one question, when you were telling me investigations, why did you mention INR? What significance that has with hematuria? Painless hematuria?
Painless, it's tumor.
Yes, but INR has significance with the hematuria.
INR, if the patient is on anticoagulant, but he was not taking, he was taking.
So that was a rough blunder, you know. Irrelevant investigation was mentioned. Reading
I'm sorry,
tendencies.
he didn't ask me anything about INR.
No, he mentioned, he told me. All right, one question. Okay, who will give feedback to Dr. Things that he mentioned, he forgot to talk about nocturia, and then he forgot to ask about any trauma.
Yeah, he forgot to ask about BPH history, frequency, hesitancy, and nocturia, and all those things.
Yes.
I think towards the end, he asked about the idea. I mean, if I may mention a small point, that he didn't ask about concerns, any other symptoms that you're concerned about, or what are you expecting from us?
Occupational history, he didn't give any importance to it. Very good.
No. No, that was my blunder actually.
No,
I didn't
no,
notice the
actually,
fact that
it was Dr. Splendor. He was supposed to ask you related questions.
no, he
But
didn't ask.
he,
Okay, like
yeah,
that. He didn't ask detailed into that. Sorry, that was my
yeah.
bad.
After, like, you told me, yes, I'm a effective worker, then
Hmm.
doctor was supposed to ask you related questions. Do you work with the dyes? What is your actual
Okay.
task that you work with? Or yeah, so effective worker was written for a reason. Okay, yes. What more?
It was a time pressure, but the moral of story is that do not take it too much empathetic.
No, but at least relevant questions you could have asked. Like nocturia, you
Practice.
can ask, yes.
Yeah.
And
Practice
then
is needed, yes.
trauma,
Forte
if patient
is a
has,
urologist, isn't it?
yeah, as a urologist. And then some
Trauma
of
in
the
foreign travel. I forgot these things. Foreign travel, trauma, and it's blood
nocturia,
thinner,
and then
Victoria,
prostatism, like BPH, rule out.
and stone passage. Stone
Yes.
passage, I think I asked about
That
stones.
stone you asked, you were like too much worrying about like if you vomited or anything, and maybe history of fever if patient was
He
having
asked that.
any kind of
No,
infection.
he asked fever.
Yes,
He asked
and
fever, ma'am. He
he
asked.
did ask fever. Okay,
Yeah.
all right.
Okay, it's
Yeah.
good feedback.
So,
So quick questions and directed and
yeah, then you'll hear the recording and kindly please note down any unnecessary question that you have asked. Erase that and change it with more relevant one. So, and you have to practice with those relevant questions. Yes, Dr. Azmi raising hand. Yes, please.
Yes, this is Dr. Azmi. Thank
Yes.
you for the presentation. Regarding the INR he mentioned in the investigation,
Yes.
it will be relevant if he asked in the history about any bleeding from
Yes.
other orifice. Yeah, it will be relevant.
Thinness or bleeding disorders.
Yes. Then he
Yeah.
could have related it with that. That I asked in the history, and then I'm telling in the investigation as well at the end to the examiner. That's why I
Can be asked in
repeated.
the history.
Yes. Yes.
Thank
You want to add anything else? Anyone else want to add anything? Thank you, Dr. Nadim and Dr. Sirdat, both of you. Thank you.